Hello, I am Dr. Nasmani, and this is the second session of the Cardiology Postgraduate Medical Entrance Test Practice session from ACPG Med. Hope that you have seen the first session, and there were 12 more videos based on Postgraduate Entrance Test question paper sessions, which was actually practice session which was transmitted for the exam going batch of last year. And this session I am starting for the new batch, so please do visit YouTube every day, and any suggestion you give regarding starting new topics, please send me email. And if the video seems to be a little faster, you can use the pause button and freeze the video till you read, and then you can use the play button again, and the total amount of video will be less than 15 minutes. It's essentially a self-learning tutorial, and some of these sessions will be having examination format, and there you have to use the answer paper ready, make the correct answer, and the timing also will be as if you are appearing for the exam, and so be prepared for that. 11 videos, or rather 12 videos, have been already uploaded in the site youtube.com/acpgmet. Please visit and practice, and more such question paper answer sessions will be there with explanation in future. I am trying to upload as many videos as possible, so please do visit YouTube daily. And also there are going to be sessions on concept bridging. That means the building concept based ideas, so that you will be able to answer more than 4 questions if you understand the concept in answering one question. That is my purpose of this video transmission, which is, of course, you are getting all over the world. So please visit the channel every day, www.youtube.com/acpgmet. Now, today's discussion in cardiology is about ostium secundum atrial septal defect, and there are 5 options given. State which one is false and which one is true. You can freeze the video after I read the answers. Often, ostium secundum atrial defect often leads to atrial fibrillation during second decade. And ostium secundum ASD is associated with the left axis deviation on the ECG. ASD, ostium secundum, is associated with the mitral valve prolapse. Then ASD accounts for the majority of cases of the ASD when compared all together. There are primum and secundum type. Whether ostium secundum constitutes maximum, that's the question. Then open heart surgery is the only option available for correction of ASD ostium secundum type. Now think about it and mark which one is true and which one is false, and let us see what is the answer. See, the statement A is a false statement. Atrial fibrillation is not that common. It usually occurs in the second decade. It doesn't usually occur early or late in life. I will discuss about it later. Then in the case of option B, actually what you see is long PR interval, then RBB, that is right blind tail branch block, right axis deviation, and you will see left axis deviation usually in the primum defect. Then mitral valve prolapse is not usually associated with ostium secundum type. Majority of the ASD are secundum type. Open heart surgery is the only option. That's not correct. It was there 20 years ago, there was the only option. Nowadays device closure is available. So if you go to the net and search in the Google, you can get the various pictures of the device closure available, amplast device which looks like a dumbbell shape or something like that. In this picture I am showing you the hemodynamics of ASD. You can see the superior vena cava and inferior vena cava supplying blood to the right atrium, and there you can see the pink blood coming from the left atrium through the ostium secundum, and the mixed less oxygenated blood from the superior vena cava, and mixture blood that is more oxygenated goes to the right ventricle, and it reaches the pulmonary artery, and since there is volume overload of the right side, you can get dilated from the right ventricle and pulmonary plethora. On your right side, you can see the types of ASD, mainly sinus venosus type, ostium secundum type, and vena cava type, ostium primum type with mitral vegetation. These are all available. This is actually the view from the right atrium appendage cut. Now the electrocardiogram in the ECG may be normal with an uncomplicated ASD and a small shunt. So don't expect all findings in ECG in ASD. Atrial arrhythmias, especially atrial fibrillation, but atrial fibrillation and supraventricular tachycardia often occur beyond the third decade. So the first option, you cannot say it is not fully false, but in young children, you don't get any arrhythmias as such. They say the P waves are typically normal with the secondum ASDs, and sinus venous ASDs are often associated with the leftward frontal plane P axis. There is negative P wave in lead 3 and AVF and positive in AVL. This leftward shift is caused by an ectopic pacemaker resulting from an ASD located near the sinus node. The PR interval may be prolonged and increases with the increasing age in ASD. So regarding ASD in children, it may not be that much prolonged. The first degree heart block can occur in any type of ASD, but it is classically present in ostium primum defect in association with a complete right ventricular block and left anterior fascicular block. The rim of the ostium primum defect is in close spatial correlation to his bundle, accounting for abnormalities of the impulse conduction through this area. The frontal plane QRS axis often ranges from plus 95 to plus 135 degree right axis deviation with a clockwise loop. Left axis deviation of the QRS axis with a counterclockwise frontal plane loop suggests the presence of a AV canal defect. QRS complex is often slightly prolonged and has a characteristic RSR or RSR pattern that is thought to result from disproportionate thickening of the right ventricular outflow tract, which is the last portion of the ventricle to depolarize. This pattern, which is often described as incomplete right ventricular block, results from hypertrophy rather than conduction disturbance. This RSR pattern is thought to result from disproportionate thickening of the right ventricular outflow tract, which is the last portion of the ventricle to depolarize, and is an incomplete right ventricular block. It results from hypertrophy rather than a conduction disturbance. And I am showing you the ECG of a ASD case, and you can see a slurred picture of the RSR pattern, even though it is not that clear. It's available in the net if you search in the Google. Hope that any of the figures or images you will see in this video can also be found out in the net. Chest X-ray in ASD, the typical chest radiograph in secondum ASD with a large left-right shunt shows cardiac enlargement and increased pulmonary vascularity. The increase in pulmonary vascularity typically extends to the periphery of the lung fields, and the pulmonary trunk and central branches appear dilated. The heart often has a characteristic triangular appearance because the enlarged pulmonary arteries prevent the normal diameter ascending and transverse ascending from the forming the heart border. The ascending and transverse aorta forming the aortic border, the heart border. The right atrium and ventricle are usually enlarged, while the left atrium and left ventricle are normal. In patients with sinus venosus defect, the insertion of the pulmonary vein into the inferior vena cava can be seen as an abnormal density on the chest X-ray called the Smitter sign. The Smitter sign is a vertical, gently curved right-sided paracardiac density that increases in width as it approaches the right cardiophrenic angle. And in this picture, I am showing you the embryology of the ASD. You can see the septum primum, ostium primum, endocardial cushion down. The septum primum grows caudally from the superior portion of the common atrium towards the endocardial cushion. and the septum primum fuses with the endocardial cushion, closing the ostium primum. Then you can see the septum secundum, ostium secundum. The second orifice, ostium secundalis, within the septum primum, and the second septum called the septum secundalis on the right atrial side of the septum primum, right side of the septum primum. And the septum secundum covers the ostium secundum but does not completely divide the atria. So during the time after delivery, when the right atrial pressure decreases and the left atrial pressure increases, this flap closes. And the last picture shows the persisting orifice within the septum secundum in the foramen ovale. That is the foramen ovale. In approximately 70 to 75% of the individuals, the septa fuse by the age of 2, closing the foramen ovale. In remaining 25 to 30%, foramen ovale remains patent, but most of the time it is asymptomatic and doesn't need any treatment. Since it is in the low pressure shunt area, it doesn't usually cause infective endocarditis. So ostium, the foramen ovale, what is called a persistent foramen ovale, PFO is a very rare cause of infective endocarditis. And I am showing you a clubbing. In this case, what is the relevance? On the child, on your left side, the child's hands are normal. On the right side, the child has got sinus and clubbing. See, in a case of endocardial Gaussian defect, you can see clubbing, whereas in atrial septal defect, which is an eccentric congenital heart disease, there is usually no clubbing. ECD means endocardial Gaussian defect. You know that in Down syndrome, endocardial Gaussian defect is the most common condition, and most of the time if the ASD is associated with MR, that is mitral regurgitation, it is an endocardial Gaussian defect like disease. So hope that this session was useful to you, and the next session will be uploaded tomorrow. Goodbye from ACPGMed. Please always visit the site every day, www.youtube.com/ACEPGMed. You can see a lot of videos there which will be useful to a student who is going to appear in the exam, and more than 20 videos have been already uploaded regarding ECG, so that's why I did not discuss more about ECG in this session about ASD. And you can also see the concept bridge practicing sessions in this channel. Thank you.